Okay. Now I'm going to say all that stuff I just said again. So what I wanted to go through today is actually just a quick kind of summary of how to do an ultrasound so that you can have somebody support you in interpretation of those images. Because I think everybody's been in a situation where you're pretty sure you're going to find something in ultrasound, and you do an ultrasound and you get to the end of it and go, I've got no idea what's wrong with this patient. And then you have to go back and start getting images and videos and things like that to then be able to send off for somebody to help you with. Where what I'd like everybody to get in the habit of doing is just doing their ultrasounds the same way every time, getting the same series of images every time, which just means that by the time you finish the ultrasound and realize you don't know what's going on, your ultrasound's done, and you know that you've got that backup and support and all the resources you need to help that patient if ultrasound is going to help that patient. So we've got there's a consensus statement on what images to get, and I've sent it through. I think everybody's seen it. And as a person interpreting remotely, we've kind of evolved a little bit beyond the recommendations in that. So the original list that we put together, which I'll share my screen. Actually, I need to open this first. Give me 1 second. Right. And coming. Where did that go? Okay, super. So what we're going to do is kind of go through the tricky parts first. So this is a summary that I've put together on the consensus statement, which just shows which images to get and which videos to get for somebody else to be able to facilitate reviewing your ultrasound. And I don't do it in my ultrasound in this order, and I don't care what order you do your ultrasound in at all. It's just really important that you do have a system or a checklist. So either or, just make sure that someone's looking over your shoulder saying you actually forgot to do this. Often you're not in our context, but often in a GP setting, you're working without an assistant and without somebody that can interpret as you go what you looked at and things. So if you're using a system, then you don't have to then go back and go, oh, I forgot to check the digital lymph node. That's probably important. So whilst this isn't my order, this is the order of things I want to talk about because it helps us to focus on the things that are kind of a little bit subjective. And we're going to start with liver because I actually find that the hardest to interpret remotely and in person, and the hardest to gain really quality images of as well. So when we're looking at the liver, does anyone have a system for how they kind of approach it? What do you want to assess when you're looking at liver?
So I often do the liver at the end of the left side and then do it at the start of the right side. So I'm still kind of thinking of the same organ. First thing I kind of assess is I'll go straight to xiphoid and get a rough idea of echogenicity, gallbladder, and like echo texture, but it's very like kind of the first point. And then I fan up the left side. And as I'm fanning up the left side and going all the way up to the edge, I'm looking at like the caudal margins. And also I feel like to assess echo texture in liver, the movement is so important. I find that still images don't always represent really subtle, like nodular heterogeneous changes. So I often, if I'm at all worried about the liver or there's liver enzymes, that's the point that I'll take a video. Is when I'm kind of like fanning up. Assessing echogenicity, I assess both it with the spleen in dogs, the falciform ligament in cats, but also the portal vasculature in the liver is very hyperechoic. So I kind of compare the echogenicity of the parenchyma to the portal vasculature and how obvious are those borders of the portal veins.
Can everyone see my pointer on this screen?
Yeah.
Yeah. So the portal veins here are the ones with a bright wall, as opposed to the hepatic veins, which is this black kind of line next door to that. Which they actually look quite different if you're assessing vasculature in the liver. Hepatic veins have not bright walls. Portal veins have very bright walls. And if they look really, really, really bright relative to the surrounding liver, then you can sort of say the liver is probably a little bit hypoechoic.
Yeah, and if they're not as obvious, you might go, okay, yeah, I do think it's hyperechoic, particularly if there's like splenic disease. I get really worried comparing the liver to the spleen if the spleen's not normal.
Disease or sedation, I will add as well.
Yeah.
Which is a little bit tricky because a lot of our
Absolutely.
patients are sedated. Yeah.
Particularly to get like the most kind of cranial dorsal views on the left and the right. I often go from the right side of the liver. I almost always will stick a probe. Actually, I always do stick a probe intercostal as well, because even if they're really sedated, that right side can kind of really sneak up. So I'll do the same thing from the right side. I start from the xiphoid and kind of like fan up and have a look around there. And then I'll look for hepatic lymph nodes and common bile duct after I've kind of had a look at the whole liver. Yeah.
Okay. So if we kind of break it down into what do we need to have in our minds when we're looking at the liver? And we talked about echogenicity. We talked about echotexture. Can you explain the difference between those two? Or what words you might use for echogenicity versus echotexture?
So echogenicity, we might refer to hyperechoic, looking brighter than we would expect, or hypoechoic, meaning looking darker than we would expect. With echotexture, we might refer to the echo texture looking very coarse, or rather than quite homogeneous. In echotexture, we might describe nodules or subtle areas where it's more hyperechoic than hypoechoic. So overall, we don't get this nice uniform texture.
Perfect. Yeah. So texture is kind of what it looks like it would be like to touch. So smooth, coarse, if there's a little bit of heterogeneity in the echogenicity, or discrete nodules or nodular. So if you've got nodules that you're like, I can clearly see the margins like well enough to measure the diameter of them, I'm going to call it nodular.
Yeah.
The important thing to note for all of these things is, and as well as size, which we haven't really talked about as much, but is it diffuse or is it focal? So is the liver is diffusely hyperechoic and enlarged with nodular echotexture would be like a really classic kind of Cushing sort of, or metabolic hepatopathy sort of description, as opposed to a mass or an abnormality that's confined to one lobe. And you might say the ventral portal aspect of the liver is hyperechoic relative to the surrounding liver with poor demarcation or whatever, if you think there's a more focal change. And that's really important because that might be a mass lesion that's not kind of showing up as a discrete round mass lesion, or it could be an infarct or a process that's only affecting one lobe. So generalized or focal, and then all of those things. Now, how do we assess size? Alex mentioned putting the probe on the xiphoid. How would you assess size on ultrasound?
I think if you're finding that those liver margins are reaching far beyond your costal arch, so you're putting the probe on caudal to the xiphoid or that costal arch, and you're still seeing a lot of liver, then subjectively, I feel like I'm quite happy that it's likely to be quite enlarged.
Yeah.
And likewise, sorry.
Well, I was going to say the angle of your probe is really important here, because you can make the liver take up your whole screen by angling, looking up under the ribs. So if you're looking kind of straight at the spine when you're right up against the ribs, then the liver should only be taking up half of your screen. It shouldn't be extending across your whole screen. And it's pretty rough. Like sometimes you get a really good impression of a big liver, but ultrasound's subjective in liver size, as is all of the modalities of assessing liver size. But you can get an impression when you're kind of relative to the ribs. If you have to angle a lot, it might be a bit small. If you don't have to angle at all to measure, to assess the liver, then it could be a little bit enlarged. What else might give you an indication that the liver's big?
The margins, like if you have rounded caudal margins, that kind of implies it. And also like how it relates to other anatomy. So in a big dog, I often find I have to push quite hard to find the right kidney. But if it's suddenly really easy to see, or the pyloduodenal junction's a lot more in the abdomen, because the liver's kind of pushing it, then those are other things that I kind of look at. So how it relates to anatomy that it normally touches and where that is in the abdomen as well.
Excellent. What are the differentials for a big liver? Broad differentials for a big liver.
If you've got sorry, Dan.
That's right. I should say metabolic disease,
Good.
neoplasia, inflammation, just broadly speaking.
Broadly? Yeah, there's one more.
Congestion.
Oh, yes. Zane's just been doing some reading on hepatic venous congestion, so I had to throw that in there. And he called it in a patient. I was like, yes, that was like actually really perceptive. Basically when you've got a big liver, there's more stuff in it, right? So when you think what's the stuff, could be cells, in which case we call it infiltrative disease, which is kind of a dumb term because nobody really understands what we're talking about. But when we say infiltrative disease, it implies cells that are infiltrating through the parenchyma rather than forming discrete mass lesions. So that could be inflammatory or infiltrative neoplastic disease. So what neoplastic diseases are infiltrative rather than focal mass lesions?
Lymphoma.
Lymphoma is the main one. Yeah, exactly. So that's the one we see most commonly for sure.
Mast cell disease.
Mast cell disease, good. Yeah. Excellent. Rarely causes hepatomegaly. Like there's rarely that many cells. It's more like once it's systemic, it's just systemic. And it doesn't cause like a big liver typically. But yeah, could do for sure. And there's one more, very rare, never seen it.
Histiocytic sarcoma.
Sorry, that's another one that I have seen, and yes, it will cause that. Yeah. Oh, sorry. Hey, yeah. Hi. Oh, have a good day. See you soon. Do you want to do your hair? Okay, sorry. All right. Like rack. When the bell goes. Bye. Bye. Okay. Walk safe, stay together. Okay, bye. Thank you. Sorry. Okay, so the other one I was thinking of is diffuse hepatocellular carcinoma.
Okay.
Oh.
So that's a kind of interesting one to put on your list when you've got diffuse changes. As I said, I've never seen it, but diffuse hepatocellular carcinoma is incredibly aggressive. If you ever do see it, apparently it's where hepatocellular carcinoma is typically a low-grade disease, diffuse is a very high-grade disease. So we've covered infiltrative, so increased numbers of cells. Obviously, congestion is increased fluid. What color is the liver going to be? What echogenicity is the liver going to be if you're congested?
Hypoechoic.
Hypoechoic, did you say?
Yeah.
It should be, but it's bright. I don't know why. I can't make it. But I don't know why. But congested livers are usually hyperechoic, quite smooth echo texture. And what marker would you look for?
Like rounded margination.
Yes, yeah. And how would you differentiate a congested liver from an infiltrated liver?
Large hepatic veins.
Vessels. Yeah.
Good. Yes. Excellent. So hepatic veins and a cava. Do we have normal ranges for those?
1-to-1 with the aorta.
Yes, good. So that's a really nice thing to be able to do. So the cava shouldn't be more than the diameter of the aorta. What's one of the artifacts or complications that we get from measuring the cava?
Volume status of the patient.
Yes, volume status of the patient. Good. I missed what you said, Jane.
Sedation and Domitor, is it? Yeah.
Yes.
Yeah.
Yeah. So if you if you slow down the heart rate with Domitor, for example, you get more time between beats. So you get more blood accumulating in the cava between the heart filling. So your cava is going to go woo, 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 with every beat because venous return is slower. And then the other thing is like it's not a really rigid structure as opposed to the aorta. And sometimes to get that view, you're pushing really hard. Have you guys ever squashed the cava when you're looking for a right adrenal? Yeah.
All the time.
All the time. So if you can get it intercostal and take that artifact out of it, that's probably better because you can't squash it if the ribs are stopping you. But it's definitely, whilst there's like reference ranges, it's definitely guidelines, not rigid. So they're the sort of things that I want you to sort of think about when you're got the probe on the liver. So size, echogenicity, echotexture, vasculature. What other situation are we particularly interested in the vasculature in the liver?
Systemic shunts.
Yeah. So typically these are younger dogs, but gosh, sometimes we've had some curly ones that have come in at 10 years of age and what ultrasound finding or clinical finding would make you go, oh, I should really check for a shunt in this patient?
Big kidneys and stones at a young age.
Stones, really good, yeah. So particularly, it's a really luxurious position when the stones have already been discovered, already been analysed, come back as urate, and then you're asked to do a scan. But actually what happens most of the time is they're coming with urinary symptoms and you see uroliths. And then you go, okay, could this be a secondary to a shunt, particularly in a young dog? So what measurement, if you're suspicious of a shunt, what extra views would you want to assess to help rule in or out a shunt?
The aorta versus portal vein measurement.
Yay. Who finds that easy?
I'm getting better, but it's still hard.
It's really hard. Zane's really good at getting it on the one screen, and you can see like beautiful portal, cava, aorta, and he's measured them beautifully together. And my shoulder's like, ow, just looking at the image. Pushed so hard to get in there. So the portal vein should be smaller than the aorta. So the ratio should be about 0.7. But if it's smaller than 0.7, then it's probably not got enough blood flowing through it or hypoplastic. So, and this is the portal vein right at the hilus of the liver. So right as it's going into the liver before it branches off into right and left. So measuring those two things and getting a ratio, if there's any question about shunt, is valuable. What's the liver going to look like if there's a shunt?
You won't see the portal vasculature. You'll just see hepatic vasculature.
What about if it's a really small shunt that's focal?
It will be focal to one lobe, so you got to make sure you look at every lobe.
I can't emphasize how easy it is to miss a shunt. There are so many different forms of shunts that might bypass only a tiny segment of liver and still be a shunt and still be causing clinical signs, still be causing urolithiasis and stuff like that. So don't look for shunts, look for markers of shunts. So if there's a focal microhepatica, for example, if there's a focal region of the liver where the portal vasculature looks smaller than the hepatic veins. And I've had a patient that I think it was an IMB patient, actually, Jane, that we were looking at, and I was like, they look a tiny bit small, but it was so subjective. And I think that one ended up having a shunt. Portal vasculature was very subtle because you can still get quite good, the dogs that have the best outcomes for surgery are the dogs that have still got quite good portal flow, but there's also a shunt. So the liver best outcome dogs, the liver actually looks pretty normal, maybe a tiny bit small, but often too subjective to make a call on. So if there's any doubt whatsoever, even if there's normal liver enzymes, if you find some uroliths, then I reckon it's worth doing that portal to aortic ratio just for a little bit of added evidence and putting in your recommendations to a bile acid just to rule out, particularly if it comes back as urate.
one thing I will say, because I've been caught out before, is making sure that you ask the vets what stones they were, because that one that I had at St. Ives, I didn't find out till after the scan that was done that they were urates. So I should have asked her.
I don't think any of us knew. I think they analysed them afterwards, didn't they?
No, they knew. It was in the report. And it wasn't until I went through the history afterwards that I realised that was urate, and I hadn't taken it.
Yeah, that's a good it's so tricky because we really don't have capacity to review all of the histories in that much detail. Very difficult.
If you're suspicious and there isn't a lot, would it be so recommendations, bile acids, and then if they come back high, CT,
angio,
or is there enough? Yeah, okay.
Yeah, so bile acids, there is no dog with a shunt with normal bile acids. So very sensitive. There are other causes of elevated bile acids, but there is no, if it's elevated, we should, and there's a small liver rather than like evidence of cirrhosis and stuff like that, then we should definitely be doing a CT angio.
So you can, bile acids, you can rule it out. If it's normal, you're like, cool, it's not a shunt, but you can't say it is a shunt. Cool.
Yeah, and yeah, you say it might be a shunt. We need to know whether this is a surgical liver problem or, so typically I'd say let's do a CT angio and a true cut if we don't find a shunt under the CT. No worries. Okay, so I'm not going to sort of go through one by one the list of images, but basically the list of images, still images and video clips that ideally we'd get are all listed in this document, which you've all got access to in the Google Drive if you can't find it in your emails or I haven't sent it around. And these are just the examples, and there are just those kind of conditional things like I don't want you to always dig for a portal to aortic ratio, but if a dog's really nicely sedated and you want to practice, go for it. But yeah, if there's any suspicion, I do want you to really prioritize it, and if you can't do it with a level of sedation, explain to the team managing the patient, look, there's something I really want to assess which would help me kind of put shunt on or off the list. I'm going to need more sedation to do it. And usually they're pretty amenable if you explain why. And then the other thing that is on our list of requirements in our kind of checklist are hepatic lymph nodes and common bile duct. If you've got a patient that you're there to assess chronic renal failure and we don't have any liver enzyme elevations and they don't want to sedate it very much for, it's been discharged late in the day or whatever it is, don't worry about checking that, like doing the hepatic lymph nodes. I think it's really good practice to get in the routine of doing it every time you can, but I wouldn't compromise patient welfare and that contextualized kind of care that we really prioritize to give more sedation to facilitate measurement of a common bile duct and hepatic nodes in a patient that doesn't have any indication of disease in that area. Does that make sense?
Yep.
So permission to be a little bit flexy with your images. Sorry. All right. So we've covered the liver. Next thing I want to talk about is spleen, because again, so subjective. The two views that are recommended to get of the spleen are that C shape, the head of the spleen, up and under the ribs, and then the whale tail insertion of the splenic vein. Now, as you know, there's a few insertions of splenic veins along the mesenteric border of the spleen. So it's not just one spot, but typically the spleen is pretty uniform in thickness at each of those insertion points. So it's really the only spot that we can measure the width of a spleen and say, we measured at this point, and I want to see if this borderline splenomegaly is progressive in 6 weeks' time, or if it's just sedation effect today. So if you've got a hunch of splenomegaly, then take a measurement across this image. So that we can kind of repeat that. What else are we assessing other than size with the spleen?
The same like we spoke about the liver, the echo texture being quite important.
Yeah.
So whether they're focal masses and describing the echo texture of them, or whether it's a diffuse change.
Yeah. Yeah, exactly. And what sort of typical changes will we see with certain sedations?
Splenomegaly and like a bit of a congested spleen.
Yeah, good. Which sedations?
A lot of them, but particularly anything that's going to alter your cardiovascular status. So like medetomidine, acepromazine. I think ketamine can cause splenomegaly, can it?
I'm not sure at ketamine. Benzos for sure. So midazolam, diazepam. They actually did a study and they measured cat splenic volumes by CT after butorphanol, and they doubled in some cats.
Oh, wow.
Yeah. So like pretty much any sedation, like butorphanol is not a sedative that I would say impacts the hemodynamic and cardiovascular system much at all. It decreases anxiety and therefore catecholamine effect on the cardiovascular system, but cats in particular will be very sensitive to the effects of different sedations. So in theory, we could be seeing that in dogs as well. I find it really hard to determine, everybody finds it really hard to determine the significance of a nodular spleen. What are the markers of nodules that we would be concerned about?
If it's
causing capsular distortion.
That's my big one. Yeah. Why?
Because that's more of like an aggressive behavior. Generally benign things kind of form to what's normal. They kind of like seep in rather than take over.
Yeah. Sort of, except for nodular regeneration causes some of the biggest splenic masses I've ever seen.
because they're at risk of causing rupture in hemoabdomen and then like significant mortality, morbidity to the patient.
Yes. Yeah.
Even
So
if
as
it's
soon as
benign.
you've got like distortion of the capsule of the spleen, then you know that things are stretched in there and they're more likely to rupture. So whether it's benign or malignant, that's a marker of risk. And that's one of the things that makes me go, okay, I think we should probably take that spleen out unless there's a contraindication for that surgery. What other like echogenicity, what else are we assessing in splenic nodules?
If they're highly cavitated, so like we discussed last night with when they're highly cavitated, you may not want to aspirate them because you may just get not a very diagnostic sample if there's a lot of blood contamination and cause a little bit of a hemoabdomen while you're doing it versus if you've got something that looks
cute.
Yeah, just a little bit. Versus if you've got a mass that's quite echodense that you feel like you'll get a cellular sample from.
Yeah. So cytology with splenic FNAs are much more diagnostic from hyperechoic nodules than they are from hypoechoic nodules. Because hypoechoic nodules are more likely to have blood contamination or be hemangiosarcoma, which doesn't really exfoliate. I shouldn't say it doesn't exfoliate. It exfoliates well, but it's just endothelial cells and blood, so difficult to interpret. So they're the sort of where I'd recommend an FNA versus just a splenectomy is hypoechoic versus hyperechoic. And if it's bulging the capsule, whether it's hyper or hypo, but I'm more like, let's go to surgery soon if it's hypo and bulging the capsule. Everything else, we don't really know what the significance is. If it's within the body of the spleen, not causing any distortion, it's probably not aggressive, but pretty much my recommendations are always check it again and just see if it's progressive or regressive or stable. Excellent. So I'm not going to talk too much about the gastrointestinal tract because really we definitely need to be able to check every section, but I think practically that's very much a practical skill to learn. Would you agree with that? We all know about the layering of the gastrointestinal tract and what it should look like, very black and white. If we start to see tiger stripes, what's that in the mucosa? What's that a marker of?
Lymphangiectasia.
Excellent. Yeah. Which can be primary disease or secondary to IBD. So it's not necessarily just a straight diagnosis. It's not diagnostic. When else might we see tiger stripes?
If they've had a fatty meal recently, so if they didn't fast them this morning.
So what that is, what we're seeing is the lymphatic vessels in all the lymphatic vessels absorbing the fat from the meal. So if they've just eaten, it's a variant of normal. So not always significant. And often we're scanning dogs and cats that have altered transit times. So it might not be that they've just had a meal. It might be that their meal just left their stomach and hit their intestine. So if there's still stuff in the stomach, then I'd probably say, okay, may not be significant. So the other thing that I want to really cover is kidneys. So 80% of nodules in kidneys are missed with ultrasound in humans. And that's because there's so much going on in the kidneys, right? Like there's so varied echogenicity. There's often little shadows and stuff like that. So there were standard views that were requested in the consensus statement is a renal length. And we want to look at that in sort of like really maximize, obviously, the length of the kidney, but we also want to get a video where you fan through the whole kidney in that sagittal section. Sagittal, yes. And then we also want to get a video where you fan through cranial to caudal in a transverse section. So longitudinal sagittal view, we measure the length on. This cross-sectional view is the standard view for us to measure the renal pelvis. So I don't always measure the renal pelvis. Like if subjectively to me it looks completely normal, there's no markers of renal disease, I won't measure it. But if there's any question about that looks a little bit prominent, then I definitely will measure it. And I'll measure it in this view. Now, something that we see quite commonly is a ureteral obstruction. And it becomes quite hard to know where the ureter starts and where the pelvis finishes sometimes when you're measuring across that V when the ureter's dilated. Has anyone experienced that? So I want you to just kind of estimate if you're in that situation. Now what isn't a very good picture of it, but these bright white lines, what are they?
Fat. Is that right?
Probably,
Like
yeah.
the calculi? Sorry, the calyxes.
Good. Yeah. So surrounding the collecting system is connective tissue, which is bright, and fat, and arteries, vessels, and stuff like that. So there's kind of this like infrastructure around the calyces heading into the renal pelvis that will really mess with your ultrasound beams because it's quite dense tissue in amongst quite hypoechoic, not dense, tissue. So we get some artifacts occurring in the kidneys, which can make it really hard to call mineralization versus like normal. Has anyone been in that situation where they've gone, oh, is that a nephrolith? Yeah. Is it significant if there's a nephrolith but no dilation of the collecting system?
Not at the time, unless you're worried about hypocalcemia and it's everywhere. Yeah.
Probably not. So stones that form in the calyces pretty much get too big to go anywhere pretty uniformly. So they'll cause if they form in the calyces, they'll cause an obstruction early. And if they've formed in the calyces and haven't caused any obstruction, they're probably not a significant thing to worry about. And if there's no other stones anywhere else in the urinary tract, you can sort of say, okay, I'm not going to chuck this dog on a urinary diet based on that finding. One of the ways to differentiate, and we will definitely miss nephroliths, and we will definitely call nephroliths that were actually like connective tissue and fat next to the calyces. One of the ways is the brightness uniform when you're fanning through the kidney? Like, is it surrounding every one of the calyces? And if it's not, then maybe it is more likely to mineralization or a focal change. The other thing that happens with the kidneys that we did actually talk about yesterday, and this is a good example, anything that's got a round edge will create a bit of a shadow because of the beam hardening artifact. So you can see it really nicely on the edge of this kidney, right? There's also round structures all through this kidney that are going to cast little shadows potentially. Oh dear, just to be a little bit mindful of. Any asymmetries in the kidney should be noted. Obviously, any alterations in echogenicity. So what sort of changes in echogenicity do we see most commonly?
Hyperechoic cortex in old kidneys.
Yeah. What causes the hyperechogenicity there?
Like increased fat deposition.
Fibrosis, yeah. So should the kidneys be big or small?
Small.
Oh, good, because fibrous tissue takes up less space. It contracts than parenchymal tissue. So if we've got a bright cortex in a small kidney, more likely to be fibrotic. What about if we've got a bright cortex in a normal to big kidney?
You could have increased infiltrates, so like increased cellular material, so like lymphoma or something like that.
Yep. Excellent. So infiltrative disease, one of the differentials for normal to big kidneys with hyperechoic cortices. What about when we've got a bright white line just at the corticomedullary junction or just inside? A medullary rim sign.
Can be very normal.
Very normal, yeah.
Yeah.
Particularly in the patients that we're scanning. So particularly in cats, we see it all the time. It's typically fat that's been deposited at that level. For some reason, fat just gets deposited there. And it's usually when there's been a period of anorexia or weight loss that we see it more prominently. But certainly can see it in like completely normal patients or patients with like quite profound kidney disease. It's not a specific marker, but something we see as a variant of normal. Now I'm going to have to wrap up, and we've got the kind of checklist. Oh, the only other thing is renal size. Dogs are so variable with their size of kidneys, right? Because they're so variable with their size of pet. So when I'm interpreting remotely, something that's not in this consensus statement, I can't see the dog. So you subconsciously go, yep, that looks pretty normal for this dog when you're doing the ultrasound yourself or when you're there. But when I'm working remotely, I can't tell whether the renal size is normal. So what we like to do is just get an aortic measurement right next to that left kidney where the renal artery is inserting into the aorta. And then we can do a renal to aortic ratio. And the ratio is quite like 5.5 to 9.5 or something like that. So it's very broad. So the normal ranges are very, like the variants of normal are very varied in dogs, but it really helps me to be able to interpret if they're big or small kidneys. Big kidneys, typically we only see as compensatory change if one kidney is injured or if there's a shunt. They're the two kind of things we see. Or if there's a big tumor in there, but that's usually more obvious. All right, I'm going to have to wrap up. If you've got any questions or anything like that, just let's kind of put them in the ops task list so that everybody can see the answers and stuff. And if anybody wants any more resources on ultrasound, like an Atlas textbook or something like that to take in your kit bag, then that's something that we can make sure that you've got access to so you can interpret as you go as well. All right.
Can I ask one very quick question about the scan I'm going to do now? It's a staging for lymphoma that's already been diagnosed.
Yeah.
You don't bother FNAing anything that looks like it could be, it doesn't change the treatment protocols.
No.
Does it?
No, exactly. Yeah. So is it a multicentric?
It's just got big submandibular lymph nodes, and it's suspect B cell lymphoma. That's what
so really we're just checking spleen and liver to determine whether it's stage 3 or 4.
Yeah.
I mean, if it's only submandibulars, it's actually probably stage 2.
Yeah. They haven't mentioned anywhere else, but they had stage 3, so it might be somewhere else as well.
Yeah. If there's intra-abdominal lymph nodes, it's stage 3 because it's across the diaphragm.
Yeah.
And if it's splenic and liver involvement, it's stage 4.
Okay.
And we
so
can't
just say probably, but don't bother FNAing anything.
I wouldn't. Yeah.
Yeah.
No, especially not. I get so scared of hepatic lympho and FNAs.
Yeah. Perfect.
Yeah.
Perfect. Thank you.
No worries at all. Thanks everybody for your time this morning. And we'll
Anna, sorry, that's just a question. I need to go. Why do you get scared of hepatic lymphoma FNAing?
Oh, it's like one of those things that you have one case that goes badly and it scars you for life. It wasn't even my case. It was just I happened to be in the hospital and this dog had a big liver and it had only hepatic lymphoma. There was nowhere else to aspirate and needed an aspirate and it bled out and died.
Oh, okay.
Just an FNA, had normal coags, like every box had been ticked.
Okay.
Yeah, it had normal liver function on bloods as well, like it was an acute liver failure, but still had like the albumin, coags, blah, 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 still all functional. And it just bled out. It was awful. And when a dog's got lympho, you're kind of like, I don't want to bleed another dog to transfuse it.
Yeah, sure. Yeah.
No good reason is the answer to that question. I'm just scared of it. All right. Thanks, guys. I'll speak to you soon.
Thanks.
Thank
Thanks,
you.
Anna.
Bye.
Bye.